My name's Anne Tait. I'm a general paediatrician at Starship. I'm not a chronic pain specialist, and I kind of thought I'd do this functional gastrointestinal disorders, mainly functional gastrointestinal pain in children first up, and then a bigger talk on chronic pain afterwards. So there's a lot of pain, unfortunately, for you guys. I'm really keen for questions, so if you've got tricky cases, don't know what to do, or things like that, I can't promise that I have answers, but sometimes it's really nice to brainstorm in these situations. The abdo pain one, the first talk, is going to be a bit more of a simplistic approach because that's kind of probably what most children have, but the chronic pain one is more overall, but also more, I tend to try and focus on practical stuff, what to do in clinic, because although I work at Starship, we don't have a huge amount of access to things like psychology or physio or fancy multidisciplinary teams, so we kind of got to have an approach there and there in clinic. So anyway, so why talk about chronic abdominal pain? So I managed to get roped into doing this presentation by being contacted by Karen at a very weak moment when I was busy and distracted organising the paediatric clinical exams and also about to go to Hawaii. I love going to Hawaii, by the way. But I thought it was a good time to talk about functional gastrointestinal disorders as well as chronic pain syndromes in children. We're seeing a lot more of these referrals in secondary and tertiary care peds at Starship. Also have a small private practice in general peds, and I'm seeing a lot of referrals. So I kind of think if I'm seeing a lot of referrals, you guys shield us from a lot of the big stuff out there, so you guys are probably seeing stuff as well. So it's a common referral to general peds, and as we're shielded by you guys, you must be seeing a lot of it. It can be, and this is about abdo pain I'm talking about, can be a lot of concern for caregivers, especially if the perception that if there's pain there must be something wrong. Google, unfortunately, has not been our friend or my friend in this situation. I've had a lot of parents come to me with the results of their search, diagnose their child with bowel cancer, diverticulitis, some sort of GI tumours. Allergies are a common one as well. I get a lot of requests for investigations and sometimes had some tricky conversations why I'm not going to do a CT or an MRI in their child. Also requests for scopes, allergy testing. And also sometimes there can be a background of family history of recurrent pain syndromes as well. There's obviously the potential for over-investigation and also a degree of learned behaviour as well. So if there's a family history of chronic pain syndromes, what is a child learning about, just normal symptoms? Also the potential for school avoidance, and what we kind of worry about is could these things evolve with time into other pain syndromes in the long term as adults? So my interest started as a means of self-preservation, as these things often do in medicine. When we're on call for general peds in Starship, we do about a week at a time. So any chronic patients admitted under my week on call are my responsibility going forward. I really never got taught much about the management of chronic pain or functional disorders in my training. And this situation was worsened when the one chronic pain specialist in Starship went on sabbatical for 3 months. And also the paediatric gastroenterology team became increasingly allergic to seeing functional disorders, and I was on call about 3 weeks over that 3-month period. So in view of that, I decided to upskill myself, and I went to Minneapolis for a week to learn these skills, and it was incredibly good. We had a lot of people from all around the world, a lot from America, also from Scandinavia, us in New Zealand, a couple of us from Auckland as well. Going back to gastrointestinal pain in children, it was first described in 1958 by a chap called Apley and colleagues. And they did this by attending 1,000 routine child health examinations in the Bristol primary and secondary schools in the UK to identify the prevalence. They found about 11% of children met the criteria for having at least 3 episodes of abdominal pain, usually mid-abdomen, during a period of 3 months that was severe enough to affect activities. But by using less stringent criteria, about 33% of these 1,000 children had some abdominal pain at some point. Comparing the study group with a control group in these 1950s children, the children with pain also reported a lot more frequent other symptoms like headaches, also more likely to have family members with abdominal pain or other somatic symptoms. The pain onset was generally around 5 years of age. Initially, girls are the same as boys in terms of numbers, but by adolescence, it would much increase in girls and reduced in boys. There was also an association with frequent, their words, emotional disturbances, such as fears, enuresis, nightmares. And the children were described in the authors, again their words, as being highly strung and anxious. So in the past 20 years, there's a thing called the Rome Foundation, and they have various criteria for these functional disorders. So we're up to Romefall now, and it's a symptom-based guideline by which child and adolescent functional gastrointestinal disorders can be diagnosed. It's a combination of consensus as well as evidence-based. In the last 10 years, it's Romefall. Now, the Rome 3 criteria, there was a sentence emphasising the importance of finding no evidence of organic disease. So that unfortunately led to quite a lot of extra testing, and particularly invasive testing. So I remember as a paediatric registrar under the guidance of my consultants in the early 2000s, referring children with recurrent abdominal pain for CT abdomens, upper GI scopes, barium swallow follow-throughs, that all with generally normal results, except for the occasional incidentaloma, which kind of heightened everyone's anxiety. But there's a new sentence in Rome 4, which is after appropriate medical evaluation, so history and exam only, the symptoms cannot be attributed to another medical condition. So the idea is that allows for selective testing or no testing. And also there's another part that functional gastrointestinal disorders can coexist with other medical conditions, such as inflammatory bowel disease, celiac disease, and we see a little bit of that. Anyway, so the next slide is about the various Romefall criteria, the functional issues. So there are things like functional nausea, vomiting is one part of it, so cyclical vomiting syndrome, functional nausea, rumination syndrome, and then there's the functional abdominal pain disorders. So that's like also dyspepsia, irritable bowel syndrome, abdominal migraine, and I'm mainly going to talk about functional abdominal pain, not otherwise specified. Also part of them is functional defecation disorders, such as constipation. So I decided to focus on functional abdominal pain, like chronic rather than acute, because acute pain is usually well taught. It's taught well in nursing school and medical school, GP, paediatric training, and there's lots of good pathological processes to think about, like UTI or appendicitis. But chronic abdominal pain is a more nuanced subject, so especially if it's a fourth or sixth presentation, an otherwise well child whose parent demands kind of action as to something to do, and sometimes they can be a bit heart-sinkish, I think. I think often adults are probably worse than children, to be fair. But having an approach that's child-focused, that doesn't over-investigate, and there's good treatment approaches, and also that hopefully everyone thinks that things went okay. And so what about the epidemiology? Well, there was one trial I found, it was in PLOS One Journal in 2015. They looked at 58 articles, nearly 200,000 children with abdominal pain, and there's a worldwide prevalence about 13.5%, so pretty close to the original Apley description. So across the kind of age spectrum in children, girls versus boys was higher. But something that I thought was really interesting is that there was pretty much even throughout all the socioeconomic groups. I don't know about you guys, but it seems to be more of a, dare I say it, middle class, upper middle class. I don't see lower socioeconomic groups, kids, presenting with this. So that was quite a kind of difference for me. And what about other things they looked at? Psychological disorders, quality of life reports. So anxiety, depression was reported significantly more. And abdominal pain is actually quite a good predictor for depression in older age adolescents. So about 2.4, 2.3 odds ratio. And also they can predict, depressive symptoms themselves can predict abdominal pain. One thing that was really interesting I found was a couple of groups did strength and difficulties questionnaire, and they found quite a high rate of conduct problems in kids with abdominal pain, which I was a bit surprised about because I've not really seen that in my own practice. And unsurprising, kids with abdominal pain had much more time off school compared to relatively well, or controls with no abdo pain. So, and there was obviously also there was stress and negative life events in children with abdo pain. There was high stress levels, much increased prevalence of abdo pain. So they had a 5-point stress scale in a few trials, and 6.3% of girls with mild stress had met the criteria for irritable bowel syndrome, but a fifth of girls with severe stress met the criteria. And also more frequent experience of domestic violence, more frequent punishment by parents, hospitalisation, sexual abuse, other forms of abuse, and children who are complaining of abdominal pain. So, but why do some children get recurrent abdominal pain and they don't, despite all that? So I worked in Oxford, sorry for the blurriness of the side, and part of my paediatric training in the mid-2000s, and there was a really experienced gastroenterologist there who always said the bowel is the seat of the soul, which I always thought was a really nice explanation later with the biopsychosocial model of chronic pain. There is a hereditary component, so although only a few specific gene polymorphisms have been identified, there's certainly a learned component in pain. And genetics probably more likely to affect a person's susceptibility and or response to treatments. In addition, the early family life can affect a child's experience of illness and subsequent symptom behaviours. And a lot of studies have shown that a child whose primary caregiver has irritable bowel syndrome has much more frequent stomach pains and non-GI symptoms, which was associated with more school absences, doctor visits, and that side of things, which, you know, when I was kind of reading that, I was going, oh gosh, it's a bit of a despair. But I feel that these behaviours can be unlearned, and I'm going to talk a bit more about this in the chronic pain lecture. And there's some really elegant studies showing the impact of parental attention on the maintenance of pain and also the reduction in pain behaviours. So what I tend to do in my clinic is I talk to young people and their parents about the brain-gut axis. I use the bowel as the seat of the soul. Visceral hypersensitivity, so pain can be affected by other areas of distress. And I often explain that there's not a single cause about this. And I really emphasise that I'm not saying that the symptoms are in the head and the pain is very real, and maybe it is due to the kids feeling normal bowel contractions as being painful or a headache in their tummy. But I try to focus on functional improvement, and that the pain improvement is usually following the improvement in function. So to try and de-escalate the situation, to try and teach parents not to ask about pain and to emphasise functional progress. And I again talk a bit more about how to do this. For those children with significant symptoms, I actually try and spend some time with the parent alone and talking about them, trying not to ask about the pain in the child, but acknowledge the pain, but then to use lots of distractions from that point of view. But it can be, and this is another diagnosis. These are really blurry. They're a bit better on my computer, sorry. So going into the diagnostic criteria, this is the Romefall criteria again, and it's quite a specified criteria. So they've got to be fulfilled, pain's got to be at least 4 times a month for at least 2 months. So it's either episodic or continuous. Most of the time in children it's episodic and doesn't occur just during physiological events. Like, you know, if they say, oh, my tummy's sore after eating and that's the only time it's sore, it's not really functional abdominal pain. They don't have irritable bowel syndrome by criteria or the other functional issues. And that's that new sentence, after appropriate evaluation, which can just be history and examination. The abdominal pain cannot be fully explained by another medical condition. So just going back next into this, IBS is on your left there and abdominal on the right, abdominal migraine. So you can see with that it's actually IBS, and I see a lot of kids they've kind of diagnosed with IBS, but they don't have the bowel issues, so that's not IBS. Okay, I don't have much experience in adults. You guys are probably better at this stuff than adults because it seems to occur a lot in adults, but you know, often I'll get the referral, oh, they've got irritable bowel syndrome. I'm thinking, oh, I don't think they have. They've got no fecal issues. So again, that sentence in italics at the bottom, after appropriate evaluations. And this one here is abdominal migraine. So that goes to your question. It's paroxysmal, intense, acute, midline or diffuse abdominal pain lasting more than an hour. And it's separated by weeks and months. And the kids I've seen have, you know, the parents have described them looking exactly like a migraine looks. You know, they're pale, they might vomit, they're photophobic, and they're severe pain, and then it resolves, and then they're back to usual activities for a number of weeks or months. But like I said, I haven't seen much abdominal migraine, to be honest. So in secondary care, I have a luxurious 45 minutes to take a history and examine and discuss management options. I suspect the same for you guys. So in the interest of time, you no doubt have to take the history from the parents. I always get the opening sentence from the parents, but I actually like to take the history from the child. And I also like to really observe the interaction between the parent and the child. So with the parent, most kids can give a history. I can take a history from a 5-year-old. They're pretty, it's easy. But if I look at it, see if the parent's trying to take over and try and dictate the process as well. In terms, and this typical pain history, going through all that side of things, which no doubt you all know. I also, when trying to judge the intensity of pain, that can be really tricky in children. I tend to use this phrase of, how bad is it for you? If 0 out of 10 is no pain, 10 out of 10 is something like your arm getting cut off, how is your pain for you? Often they'll say 10, or they just guess a number, but it doesn't really matter from that point of view because it's subjective. In primary care, you probably know your patient's family social history, but we don't. So I take a lot of time going through that. I often do it when I'm examining the child as well. I take a pretty detailed history of any functional chronic pain disorders as well as the family dynamics. And I kind of also ask to say to parents, what do you do when your child's in pain? What do you care for them? What do you say to them? How do they respond to that? And that's what I'm trying to figure out, is whether the child's receiving lots of positive attention, which actually paradoxically can worsen the pain or maintain the pain for longer. But that's a bit more in the chronic pain talk. So examination, the assessment, growth is a really big thing, and growth velocity over time. Growth is a really sensitive indicator in pediatrics of something going wrong. So if their height is starting to fall off, if their weight is falling off, and that. Unfortunately for older children, we often don't get growth measurements. We get it at the time of the clinic, but we don't have a pattern over time. Even in tertiary pediatrics, you'd be amazed at some of my tertiary colleagues don't routinely plot out growth and that, but it's important to do. I always have a quick look at the mouth for ulcers, thinking about inflammatory bowel disease. I do a really proper abdominal exam, light and deep palpation, percussing, so people can see that you're going through the performance as well. Have a quick look at skin and joints. In terms of investigations, you can consider nothing. If it's a 6 or 7 year old, they've got a bit of tummy aches, they're going to school, they're otherwise fine, there's no red flags, you can consider doing nothing. But if they come to me in secondary care, if it's not already done, I usually always do a full blood count, a CRP, celiac serology, IgA, because sometimes if you're IgA deficient, your celiac serology will be low. Renal functions, liver functions, I put plus minus, but I tend to do them. In terms of things like fecal calprotectin for inflammatory bowel disease, I probably really only do that if they've got diarrhea or had some blood, or if they've got ongoing abdo pain. The gastroenterologists like that. They kind of think there's the occasional case of small bowel Crohn's. To be honest, never seen it, but they see a different population. But generally not indicated as imaging studies. We don't need an abdo x-ray if they've got no history of constipation. So they don't need an ultrasound. They certainly don't need allergy testing. There seems to be a bit of I often get the question, is it an allergy? I'm like, no, it's not an allergy. Upper GI scope, certainly not. CT, abdomen, MRI, barium swallows, certainly not, which is different to what was kind of done when I was training. So red flags, hopefully most of us would recognise all these. So weight loss, deceleration of linear growth, diarrhea, unexplained fevers, night waking with pain, family history of inflammatory bowel disease, delayed puberty is another one as well. And also the other one is all the examination findings. But what about the kids with just bog standard recurrent abdominal pain? What is the long-term sort of, or the rates rather, of pathology? And there was one study I found looked at this. It was a longitudinal study, 392 patients aged 5 to 15 years in a gastro clinic, and over time, so they fit the Rome 3 criteria, which was around at that when they were looking at that. So over time, only one child developed pathology. Of that 392 who fit recurrent abdominal pain not otherwise specified. So 1 child later developed ulcerative colitis, 2 developed MS, not really related to the original presentation. So if they haven't got any red flags and they fit those Romefall criteria, I think you're pretty confident that there's not pathology there. So you've got a patient, what to do now? So what I tend to do is really emphasise the commonness of this condition. So I say, look, to parents, it's a common issue. About 15% of children between 5 to 15 years of age. And for over 50% of these children, these symptoms resolve with time. Usually investigations are not needed. I really emphasise the positive findings, so no red flags, normal growth, normal examination, both to the parents and in my letter. And I explain what normal is. So from a parent point of view, they kind of think, oh, my child's got pain, therefore there's something wrong. But actually, this is a normal issue. And what I've learned over the years is ask what people have Googled. Because I find that, like I said, I've had a few interesting answers. And sometimes there can be some elderly relatives that said, oh, I've had diverticulitis, this looks like that, or whatever. So rather than saying you'll be fine, so I explain more about why their child will be fine. And hopefully this means that people don't feel dismissed, that their concerns are acknowledged. And also if they are worried about certain diagnosis, what they've found, that I explain why it's not about a cancer or a hiatus hernia like Granny had or whatever. So my management approach, I'm pretty minimalistic, a lot of reassurance, acknowledgement of the pain. This is for parents, but not asking about the pain. Lots and lots and lots of distractions. We'll talk about that in the other things. Things like heat packs, I just don't want to try and focus on the pain, but if they're really bad, say some heat packs, but then do some fun stuff. But a big thing is normalisation of activities, getting the kid back to doing their normal things and making sure they attend school. So with regards to distractions, talking about interesting things, this is how I coach the parents what to do in this situation. What are you going to do on the weekend? Patting the dog or the cat, asking them about their favourite activities, playing games, and getting some exercise, getting out to the park, going to school, and certainly as a result of my reading, I'll really reinforce that study I talked about briefly, the 392 patients longitudinally, only 1 had pathology. I'm trying to minimise the 1 because everyone thinks that child is their one. Their child is the 1 patient with their pathology. And I provide lots of info sheets. I really like this one. This is from the North American Gastrointestinal, Pediatric Nutrition. I can give you I've got a photocopy of it here. So I always give them lots of info and that. And I always say, be careful about what you read on the internet, because a lot of it can be rubbish and not applicable to their situation. And for those of whom the basics don't work, like you've done all that and are still coming back to you again and again, the kid's paining away, well, sometimes we do have to do an ultrasound. We just kind of cross our fingers that we don't find anything, because it's kind of it can be more of a reassurance. So blood tests, if they've not already been done, so especially celiac serology. A stool sample, every kid seems to, when they come into my clinic, they've usually had a stool sample. I've never seen a positive one, but again, it's kind of reassurance. I always worry about finding stuff like erymonis, which doesn't mean anything, and then everyone gets panicked about stuff. If an older child's coming back, or other in any age group, but I always look at doing a HEADS assessment in the older children particularly. Is there depression? Is there anxiety? What's going on at home, at school, anything else? Although I often find with the young people it's taken a few visits before kind of they're fessed up to what's going on. Going through what a typical diet is like, focusing on lots of fruits and vegetables, not so much processed food. Going through their sleep as well, sleep patterns, sleep deprivation's a really good marker of overall function, and sleep deprivation can maintain pain. Exercise, what sort of I'm very much focused on my sports, but, what are they doing? And also school attendance, obviously. Are they still attending school? But also sometimes people say, oh, yeah, they're going to school every day, but they're spending most of the time in the sick bay, which is... So, and I've learned to actually ask, so if they're going to school all the time, are they going to the sick bay? What are they doing during that time? So I'm going to talk a lot about this more in the chronic pain, but it's an introduction to the tricky kids, the kind of rehabilitation approach. So the exercise, sport, school attendance, social activities are the big focus. A lot of parents seem to be concerned about lactose intolerance, so I sort of explain why the kid's not lactose intolerant, because they're not having explosive diarrhea. Gluten intolerance or other restrictive diets as well. This is more of an adult thing, but there used to be a push to more fibre, like Metamucil. I've never really found it helpful, and studies haven't shown that for children. Sleep, really important to think about that, and I always do a sleep, review of sleep patterns. Sleep deprivation, as we know, can impact upon mood and pain. I'm very much focused on daily exercise, particularly walking or scootering or getting to the park, from that side of things. And as you can kind of see from medication, it's not a big focus for these kids, the recurrent tummy painers. Probiotics seems to be the flavour of the year. I don't know, you guys get asked about that. I always get asked about that. I should have invested in some. I would have made a lot more money. We don't. I always say to parents, look, we don't know what a normal microbiome is. We don't know. We know everyone's microbiome is entirely different because it's based on what we eat. It's based on if we've had antibiotics recently, and we don't know really what is available is what is easy to manufacture. We don't know how much probiotics to use, and the studies have been pretty disappointing. So, and that's given the positive publication bias. So I don't tend to recommend it. So my summary of recommendations for what I do in secondary care and what's reasonable for the tummy painers: history and exam, targeted investigations, a lot of reassurance about the lack of red flags and or existence of pathology. I provide information sheets. I educate people about the brain-gut axis. I talk about the bowel, the seat of the soul, whether it's feeling normal bowel contractions as being painful or a headache of the tummy. And the focus is distractions, school, exercise, and some brief psychological strategies, which I'll again talk about at the next appointment. So it's kind of my good enough approach. And that's what we talk about in general peds at Starship. We talk about a good enough. We don't have, access to the beautiful gold standard multidisciplinary stuff. And the idea is to try and prevent the over-focus on pain, to normalise the existence of tummy pain. We all get some pains, continue the usual daily function. And hopefully that'll stop the little tummy painers growing up to be big tummy painers, although I don't have a lot of evidence. There's a few studies, which I'll talk about in the next talk, about that, and the tricky ones. So it's kind of tempting to do this, but in the chronic pain part of the talk I'll discuss the approach that we use at Starship, and it's kind of been adapted from a number of practices overseas. We've kind of modified it for general peds clinic. Like I said, we don't have a huge amount of access to physio, psychologists, other multidisciplinary team members, so we kind of try and do a good enough approach.